My name is Emilie Reas. I'm an assistant professor in the Department of Neurosciences at UC San Diego, and I'm very excited to share a new study that my team is conducting examining blood-brain barrier disruption with anti-amyloid immunotherapy, with the overarching goal to guide safer treatments for Alzheimer's disease. So we are at a pivotal point in Alzheimer's disease research with the FDA approval of the first disease-modifying treatments for Alzheimer's disease. These treatments, known as anti-amyloid immunotherapies, target the underlying biology, namely the amyloid beta plaques that accumulate in the brain. So anti-amyloid immunotherapies that are FDA approved now include lecanemab or Leqembi and donanemab or Kisunla. Both lecanemab and donanemab have shown excellent efficacy at clearing amyloid plaques from the brain as measured by amyloid PET. So in both the lecanemab and donanemab clinical trials, patients receiving the drug, shown here in yellow, demonstrated marked removal of amyloid compared to the placebo group in blue that remained relatively stable throughout the 18-month treatment period. In addition, these drugs have shown some efficacy at slowing disease progression. So as you can see in these graphs, both the treatment group in yellow and the placebo group in blue show progressive clinical decline over the course of treatment, as demonstrated by a reduction in scores on the clinical dementia rating scale. However, you can see that the treatment group in yellow declined at a slower rate, approximately 27% less progression for lecanemab and 29% slower progression for donanemab. However, these drugs are not without side effects. Most side effects are mild and include infusion reactions or something that we refer to as ARIA, which stands for amyloid-related imaging abnormality, because we can detect it on a brain MRI scan. Now, ARIA comes in two flavors, ARIA E and ARIA H. ARIA E reflects swelling and inflammation in the brain, whereas ARIA H reflects bleeding in the brain or microhemorrhages. Now, usually ARIA is asymptomatic, but in some cases it can cause more serious symptoms. We don't understand exactly what causes ARIA, but the clinical trials have identified certain risk factors. These include a higher drug dose, more advanced Alzheimer's disease pathology, or the presence of a gene called ApoE4. Now, ApoE4 is very interesting because it increases risk for Alzheimer's disease, and we now know that it also increases risk for ARIA. For example, in the donanemab clinical trial, we can see that ApoE4 non-carriers showed roughly 16% ARIA incidence. However, those with one copy of the ApoE4 gene had an increased risk to 23%. Those with two copies of ApoE4 had an even further increased incidence of ARIA up to 41%. So what causes ARIA? Well, as I mentioned before, we don't fully understand, but we have some evidence from animal studies and from related human conditions of what might be contributing to ARIA. So we know that amyloid beta accumulates both in the brain tissue and in the brain's blood vessels. Now, administration of the anti-amyloid immunotherapy can transport the amyloid beta from the brain tissue to the blood vessels. We believe that the antibody clears amyloid beta through the blood vessels, which inadvertently can cause some damage to the blood vessels. The antibody can also cause a local immune response, which induces inflammation wherever the amyloid beta is located. So altogether, these processes could result in brain swelling, inflammation, and damage to blood vessels. Now, we and others believe that the blood-brain barrier might be an important player in this process. So the blood-brain barrier is a protective covering around blood vessels that is present only in the brain. The purpose of the blood-brain barrier is to maintain a healthy homeostatic environment by regulating which substances can enter the brain, such as nutrients or immune molecules, or exit the brain, such as amyloid beta or other waste products. Now, we know that the blood-brain barrier becomes more permeable with age and even more leaky with Alzheimer's disease. Findings from my lab and other groups have shown that ApoE4 carriers have a leakier blood-brain barrier than non-carriers. And we found that this is even prior to any cognitive decline or even prior to amyloid beta accumulation. So far I've shown you that ApoE4 is associated with increased risk for ARIA. It's also associated with increased risk for leaky blood-brain barrier. So this raised the possibility that there could be a link between blood-brain barrier disruption and risk for ARIA. So this is the focus of an ongoing study that my lab is conducting, specifically examining if ARIA might cause blood-brain barrier leakage, and conversely, if blood-brain barrier leakage could increase risk for ARIA. Now, in addition to ARIA, both lecanemab and donanemab have been associated with a very paradoxical finding of increased brain volume loss. So, as you can see here, relative to the placebo group in black, the treatment group in these colored lines showed faster loss of brain volume. Now, typically, we interpret brain shrinkage as indicating neurodegeneration or the loss of brain cells. However, in these studies, the brain shrinkage was related to greater amyloid clearance, suggesting that perhaps it's not harmful. So a very important question remains as to whether treatment-related brain volume loss reflects accelerated neurodegeneration or perhaps the resolution of inflammation from the treatment or something else. Now, we can measure these critical brain properties using a technique called magnetic resonance imaging, or MRI. So there are different forms of MRI that we can use in our studies to address these questions. Specifically, we can use dynamic contrast enhanced MRI, which is essentially a structural MRI scan paired with a contrast injection to measure leakiness of the blood-brain barrier. In addition, there's a technique called diffusion MRI that allows us to measure brain microstructure, including, for example, inflammation, cell density, or the connections between cells. Now, we are using these advanced MRI techniques in a recently launched study to address three hypotheses. First, does a leaky blood-brain barrier predict risk for ARIA? Second, does ARIA increase the leakiness of the blood-brain barrier? And third, how does anti-amyloid immunotherapy affect brain microstructure, for example, inflammation, cell density, or cell connections? And we are very fortunate to have this research study funded by an R01 grant from the National Institute on Aging. So we are actively enrolling participants for this study. In order to be eligible, an individual must be age 60 years or older with a diagnosis of mild cognitive impairment or Alzheimer's disease. They must also be a candidate for lecanemab or donanemab as determined by their physician, but critically, they cannot have already started treatment. They also should be safe for MRI and a gadolinium-based contrast injection. Now, the study protocol involves a minimum of 2 sessions located at the UC San Diego Health Campus. The first session occurs just before the start of anti-amyloid immunotherapy, and it involves 2 visits. The first visit includes a blood draw and cognitive testing. The second visit requires an MRI with contrast. Now, the second session would occur 1 year after treatment start, and it would be identical to the first session, namely visit 1, including a blood draw and cognitive testing, and visit 2, an MRI with contrast. Now, visits 1 and visits 2 for all of these sessions should be scheduled within 6 weeks of one another. Now, there's an optional third session that would occur if ARIA is detected at any point over the course of treatment. And this session would involve a blood draw at visit 1 and then an MRI with contrast at visit 2. So, what are the risks and benefits of participating? Um, so, MRI is associated with certain risks, primarily discomfort or anxiety. So, the MRI scan requires lying down in the machine, some exposure to loud noise, although we do provide earplugs, and some participants might experience claustrophobia from being confined in a small space. In addition, um, if an individual has contraindications to gadolinium, for example, if they have an allergy to gadolinium or if they have a history of kidney disease, they also should not participate. There are certain benefits from participating. Additional information will be available to be shared with the participant's physician. This includes MRI data, cognitive data, and blood biomarkers. We compensate $50 per completed visit. And broadly speaking, participation will help to contribute to knowledge that improves the safety and efficacy of treatments for Alzheimer's disease. However, it's important to note that one's decision to participate in our study would not affect your clinical care or treatment plan. So, if you're interested in participating, you can contact one of our fantastic study coordinators. We accommodate both English and Spanish language preferences. Charlotte Rivera and Cassandra Portillo are both our study coordinators who can help answer questions about the study and screen for eligibility. Now, I'd like to conclude by just thanking my fantastic co-investigators, including our neurologist team of Dr. Soria Lopez, Leger, Galasco, and Bevins, as well as my fantastic lab members, especially Charlotte and Cassandra, who have been leading study coordination. I'd also like to express my gratitude once again to the National Institute on Aging for funding this study and to the UCSD Alzheimer's Disease Research Center for their ongoing support. And thank you for your attention.